Hey everybody, my name is Vidit Bhargava. I'm a pediatric critical medicine faculty at University of Alabama, and today we're going to talk about focused assessment of transthoracic echo, which is also known by point of care echocardiography and a focused echocardiography. So let's dive into it. So as you can imagine, the subject of echocardiography can be quite broad and there can be a lot of things that we can talk about. But I think to begin our journey, we need to focus on a few different things. The biggest one is the why of it. The next most obvious thing is what are some things that I can do as a person doing a point of care exam? What is the technique of doing it, which includes the selection of the probe and some of the basic cardiac views? And then finally, we look through the quantitative assessment of LV function. So the most basic uses of cardiac ultrasound, especially in pediatric critical care, is the assessment of global systolic function. Even breaking it down a little bit more, I generally think of it as use case for LV systolic function. And then as you get more proficient, you can even start looking at the RV to assess whether a patient is going to be fluid responsive or what is their overall volume status, if there is an effusion around the heart, and if it is causing a significant amount of hemodynamic impact on the patient. And then finally, it can be used to compare the size of the RV and the LV, as well as to decide if a patient has some amount of pulmonary hypertension. Recently, in the last couple of years, a lot of professional societies have started coming out with some recommendations and guidelines on what an average pediatrician who is practicing critical care should do in terms of focused echocardiography. And it is with the intention of making sure that there is some amount of standardization of practice, as well as we are able to practice in a safe and effective manner. So these are the five big takeaways from the most recent recommendation by American Society of Echocardiography. It is that cardiac focus should be used for assessing hypotension, shock, LV, RV function, pericardial effusion, and preload or volume status, everything we talked about in the previous slide. It should be used with extreme cautions in patients who have a congenital heart disease. Especially, this is where a focused exam is very different from a comprehensive exam, and so utmost caution needs to be maintained. If the patient has mild systolic dysfunction, that is generally found to be hard for a focused exam to pick up. And so if that is suspected, a formal consultative echocardiography must be obtained. And then even in patients with congenital heart disease, it can be used in some acute situations, but generally those are reserved like we talked about. The rationale for performing a focused cardiac ultrasound is that generally, either by diagnosing things that were not sufficiently diagnosable by using physical examination alone, or by diagnosing them a little bit faster, generally the outcomes are going to be better in patients who receive an ultrasound. So, that being said, let's dive right into how to perform a focused cardiac exam. So the probe that's commonly used to perform a cardiac exam is known as the phased array probe or the cardiac probe. Generally, it's a low frequency probe, usually working at 3 to 5 megahertz, and has a small square footprint, which is designed to fit in between the rib spaces. For younger children, sometimes smaller probes are available, which have a smaller footprint, but that may or may not be available on your machine, and that's absolutely fine. The big thing to remember here is that the probe marker has to be on the right of the ultrasound screen, and the patient is positioned generally in a supine position, but sometimes a left lateral position can be helpful in certain views, and we will discuss that. So in terms of the views, there are the four basic views that I think about. There is the parasternal long and the short axis view. There is the apical four-chamber view. And finally, there is the subcostal four-chamber view, which is also the view from which IVC can be looked at. So let's dive a little bit more into the parasternal long view. So the probe is generally placed in the second to third intercostal space, and it is supposed to be close to the sternum. This is an important thing to remember because it will help avoid the shadow of the lung that may creep into this view if you're not close to the sternum. The probe marker on the probe itself is towards the patient's right shoulder, and that allows us to get a view similar to the one seen in the cartoon here, where you see the RV, the aortic outflow tract with the aortic valve, the left ventricle, the left atrium, and the mitral valve. This view is great to determine the patient's cardiac contractility. It is a helpful tool in assessing which patients have pericardial effusion. And then there is a lot of information that can be obtained when comprehensive cardiography with this view, but for our purposes, we will keep this discussion a little bit focused. Slide that helps understand a little bit about what the scanning plane is. So as you can see, the scanning plane passes through the structures that we just looked at, and based on which way the probe is angled, you can see more structures. So for example, if the probe is angled towards the apex of the heart, you would start seeing more of the LV apex, versus if the probe were to be tilted in a different direction, you could start seeing more of the aorta. So here is an ultrasound picture of what this view looks like. So you see at the top of the screen, there is the right ventricle. Just below that is the left ventricle separated by the interventricular septum. There is the aorta with the aortic valve. And then finally, there is the left atrium. There are a couple of different things to remember here. The first is that generally the right ventricle is a much smaller structure in this view, and it generally does not take more than 1/3 of the space of the screen. The other thing to remember is the right ventricle, the aorta, and the left atrium, are generally about the same in size, and sometimes they are described as the three musketeers. So if one of them seems to be disproportionately large in size, that must be paid attention to. The third thing is at the lower part of this screen, you can see that there is a bright white line. This represents the posterior pericardium, and it is a helpful landmark when we're trying to look for pericardial effusion. The other just general things to notice is that the depth should be reduced sufficiently so that there is not a lot of extra space at the bottom of the screen. This allows for the images to look bigger and better. And so remember to optimize that. And then the other thing is to optimize the gain. The gain should be increased or decreased such that fluid-filled or blood-filled cavities appear black in color, while the rest of the other organs are in different shades of gray. Next, let's look at a video of the parasternal long axis view with no abnormal findings. So this is a completely normal clip. And again, we can visualize the right ventricle, the left ventricle, the aortic outflow tract, and the left atrium along with the mitral valve. Next, we will move on to the parasternal short axis view, which is obtained in exactly the same spot as the parasternal long axis view. The only thing that is done different is that when you get a good parasternal long axis view, you rotate the probe clockwise 90 degrees towards the left shoulder of the patient. The probe marker in this case, as I mentioned, would also be towards the left shoulder of the patient. So just remember that. And generally, the view can be obtained at many different levels in this plane. The view that we are concerned about the most is those at the level of the papillary muscles in the LV. And so we're going to take a look at some of the ultrasound pictures and videos to understand that better. Um, as with any other view, this view can have multiple uses. However, for our purposes of a limited exam, this is helpful for assessing cardiac contractility and then for assessing RV-LV configuration in cases where we suspect that the RV pressure may be elevated. Here is another example of the same view, this time showing what is the plane of the cut and the appropriate structures you're supposed to see at that level. Here is a still image showing an ultrasound picture of the peristernal short axis view. Here you can see the left ventricle, which is present as a rounded structure. You can see the left ventricular wall. Also visualized is the interventricular septum, which is nice and round and bowing into the right ventricle. And then you can see the right ventricle, which is present as a oblong or triangular structure. Generally, my fun way of remembering this view is to think about the LV as an orange and then the right ventricle as the banana sitting on top of that. So if the normal RV LV configuration is disturbed, it wouldn't appear so. So here is a clip of the parasternal short axis view. And as I mentioned previously, you can here see the rounded LV along with the interventricular septum that's bowing into the RV and then the oblong RV on top. So let's play that clip one more time. I should say that this image isn't a perfect clip and probably the gain can be increased a little bit, especially in this near field of view. But nonetheless, not always do we get perfect pictures. Here is another example of a parasternal short axis view. Here the gain is a lot more optimized, and so it's much easier to see the LV cavity as well as the RV. This view is at the level of the mitral valve. As you can see that there is a fish mouth appearance to this, and so overall a good quality image. Moving on to our next view, which is the apical four-chamber view. This is the view that gives trouble to most providers who are trying to obtain this view in the beginning because of its unique position. And it is also the view that is considered to be the most informative. And as you try to learn more advanced echocardiography, you first have to master this view. So for the apical four or five chamber view, generally the probe is placed at the point of maximal impulse. For a lot of patients, that is usually at the fifth intercostal space, close to the left anterior axillary line. It can be easily found on palpation. The probe marker is generally at the 2 o'clock position, usually in the left axilla. And then the probe has to be fanned down so that it is more flush with the screen, so that, excuse me, it is more flush with the skin so that you can see more of the atrias and the ventricle. The structures that are expected to be seen here are the right ventricle, the left ventricle, the tricuspid and the mitral valves, as well as the right atrium and the left atrium. However, a lot more information can be obtained from this view. From a focused exam perspective, it is very helpful to assess the relative size of chambers. It is a great view to assess for presence of tamponade-like findings. And then there is a measure known as the velocity time integral, which is used to predict function and a patient's fluid status. All right, so here is the scanning plane for the apical four-chamber view along with the associated structure. It also gives you an idea of where the probe marker needs to be placed. Next, we move on to a still image of an apical four-chamber view, and you can see here that this is a really nice picture because here the apex is being formed. It is hard to call a view an apical four-chamber view unless you can see the apex and all four chambers, which is really nicely seen here. The other key characteristic of this view is that the interventricular septum is in the center of the screen, and that's another good example. We can see the left ventricle, we can see the right ventricle. Generally, the right ventricle is about 2/3 or 60% the size of the left ventricle. And then further, you can see the left atrium and the right atrium. One other thing to keenly observe is that generally the tricuspid valve sits a little bit lower and more towards the ventricle compared to the atrium. And this is a finding that helps sometimes decide which side is the left ventricle, which side is the right ventricle, along with all the other findings. Here is an example of an apical four-chamber view clip. Again, the overall view is quite good. you can see the apex almost being formed. The interventricular septum is in the center of the screen. We can see that the LV is larger in size than the RV, and then all of the um, other chambers can be seen quite well. One distinct feature is that in this clip, we can see a descending aorta as well towards the right bottom of the screen. Here's another clip of the apical four-chamber view, except now in this case, in the center of the screen, we can see the aortic outflow tract. And so that makes it a really nice apical five-chamber view. Our last and final view of a limited echocardiogram is a subxiphoid view. Here the probe is placed right under the subxiphoid process. Sometimes it is helpful to move the probe towards the liver and use it as an acoustic window, which can easily help get rid of all the bowel gas pattern that sometimes makes it difficult. The other things that can sometimes be helpful in obtaining this view is asking your patient to bend their knees and bring them closer to the abdomen. The probe marker here is generally towards the 4 or 5 o'clock position. Sometimes people also describe it as towards the left hip of the patient. And while we can see many different structures based on what level we are at, generally the view that you want to obtain is where you can see all four chambers in one view. This view is especially helpful for recognition of tamponade, presence of pericardial effusion, and sometimes we've used it to confirm central line placement when a wire can be seen within the right atrium and hopefully never in the right ventricle if it goes too deep. This is the view that shows the plane through which a subxiphoid view is generally obtained and the associated structures that are seen with this view. So here is a still ultrasound image of the subxiphoid view. As we can see from the cartoon, here is the liver that's seen at the top of the screen. The next structure after that is generally the right ventricle. And then further, you can see the left ventricle, the left atria, and the right atria present in that order. This is an ultrasound clip of the subxiphoid view. Like we mentioned earlier, you can see the liver at the top of the screen, followed by the right ventricle, the right atrium along with the tricuspid valve, and then the left atrium, mitral valve, and the left ventricle. All right, so now that we've talked about the four basic views of the echocardiography, it is now time to put it into a little bit of practice by discussing what are some of the common pathologies that we can look at and seeing some examples of that. And so broadly, we're going to talk through what is the way to assess normal LV systolic function. Generally, we're going to do that only qualitatively, but there are ways to measure it quantitatively as well, which we will discuss in future lectures. We will look through some examples when the function is either diminished or it is hyperdynamic. We will also see examples of a patient with pericardial effusion with or without findings of pre-tamponade. And then finally, right ventricular hypertension or right ventricular strain in a patient with pulmonary hypertension. So let's dig in. So when qualitatively assessing the function of the left ventricle, generally the things that I look for are first, I look for the anterior mitral valve leaflet and see if that leaflet is moving close to the interventricular septum with each beat. Generally, this is seen in the parasternal long axis view and is an especially helpful aid. Next thing I look for is there contraction and relaxation of the septum during diastole and systole, and this is also seen pretty well in the parasternal long axis view. In the parasternal short axis view, if we imagine the left ventricle as the mouth of the fish, then what I'm looking for is to see if if I place a finger in the fish's mouth, is the fish chomping down on that finger? And if it seems like it is doing that, then I can make a reasonable assumption um, that the function is normal, except that just one view is almost never sufficient, so you have to use information from more than one views. And finally, the movement of the anterior and posterior ventricular walls is useful to notice and see, and this is generally done in all four views before a final determination of the function can be made. So let's look through some examples of what a normally functioning heart can look like. So from the top of the screen to the bottom, first we'll see the parasternal long axis view. So here we can notice that the anterior valve leaflet of the mitral valve is moving close to the interventricular septum. We can also notice from the same view that the interventricular septum is bulking up and going down in size between systole and diastole. Next, we move to the parasternal short axis view, and as we talked about, if the LV chamber was the mouth of a fish, and if I were to put an imaginary finger in the fish's mouth, it seems to be nicely biting down on that finger. And so it makes me think that the function here is largely normal. In case of the apical four-chamber view, I can see that the mitral valve is opening all the way towards the interventricular septum, and those anterior and posterior walls are moving towards each other quite nicely, both in the apical view as well as the parasternal view. And then finally, if I were to pay attention to the subxiphoid view, I can also see that the anterior and posterior wall seems to be moving quite well. Sometimes there are some indirect indicators that the patient's function may be diminished. What can be those in terms of left ventricular function? So generally, dilation of the LV chamber or the left atrial chamber can be suggestive that the patient's function may be diminished. So pay close attention to that. Next, we'll look at some examples when the function is diminished. These are three examples where the function is severely depressed. And I've chosen these images on purpose because we want to be able to recognize things that are simple right away and for everybody to understand that to diagnose a patient with moderate to severe function, it's fairly easy, even if you're looking at your first set of images ever. The other things that should be paid close attention to here is that the left ventricle cavity is extremely dilated. The left atrial cavity is also dilated, especially if we compare it to the right ventricle and the aortic outflow tract. Moving on to our image in the center, which is the parasternal short axis view, again, we can see that that fish mouth is necessarily not biting down on the finger. And then finally, in our apical four-chamber view, in this view, we don't really see the RV super well, but I think that's partly because of the fact that the left ventricle is quite dilated and it doesn't seem to be moving as well as some of the other views. So hopefully that helps think through some of the function-related things. I also wanted to add some pictures here of the heart when the function is diminished, but it's not so obvious, right? So here is the first example of a parasternal long axis view. Right off the bat, I can see that my left atrium is much larger in size than the aortic outflow tract and the right ventricle. So that makes me suspicious that the function could be diminished. Next, I look at the mitral valve and see if it is opening all the way and abutting that interventricular septum. And in this case, it does not seem to. And then as I start paying more and more attention to these subtle findings, I notice that the anterior and the posterior walls are probably not moving as well. Next, we move on to our center slide, which shows us the subxiphoid view. Again, it is quite noticeable here that the anterior and the posterior walls are not moving as well towards one another. And finally, in the apical four-chamber view, we can see that the valve is not opening as well and the walls are not moving towards each other. So this is a little bit more of a subtle finding, especially if you're looking at them the first few times. And so I would encourage you guys to go back to this a few times before you move on to the next example. All right, and so in our series of function, the last thing I wanted to show you guys is an example of hyperdynamic function, which is when the the patient is either tachycardic for one of many reasons that patients can be tachycardic for. The next thing is they are slightly volume depleted and they are trying to augment their cardiac output as best they can by being tachycardic. And so, generally, in those cases, the anterior and the posterior wall of the LV are generally completely collapsing on each other, and you can almost always see that the septum is completely slapping the interventricular septum in this case. And so the first picture is the parasternal long axis view, where the findings we just described are seen. The second one is the parasternal short axis view, and then finally in the apical four chamber view. One of my hopes is that by this point you're trying to see that I'm using multiple views to corroborate my findings, and it is never just one thing alone. So always be wary of making any judgment based on just one picture alone. Here are some examples of pericardial effusion. So the first image is a really nice subxiphoid view, which is generally my preferred view if the only question I have is a pericardial effusion. This is also the same view that we often obtain in a FAST exam, and so it provides us very quick and nice information about the presence of pericardial effusion. The spot that I generally look at is right below the liver and the pericardium because that is the most dependent area. And sure enough, in this picture, we can see that there is a small black or anechoic triangular fluid collection, which is a small size pericardial effusion. The next picture is in the center of the screen, and that shows an apical four-chamber view. It isn't a perfect apical four-chamber view because, like we said, even though it's forming the apex, the interventricular septum is not in the center of my ultrasound screen. So sure enough, the image can be improved, but what we can see here is that there is a circumferential moderate size effusion that's present. There is maybe a little bit of side to side movement of the heart, which is sometimes described as a swinging heart. Certainly, it is a finding when there is a large pericardial effusion and is quite concerning. But even in this case, you can see that. The third example is something to pay really close attention to because here, if we look closely at the right ventricle and right atrial walls, we can see that the walls are collapsing on themselves in diastole. This is usually indicative of the fact that the patient is going to either have some tamponade-like findings or the patient is already in cardiac tamponade and we may have to act quickly. So even though in this finding or in this clip, I cannot see a large fluid collection, I can obviously see some. I'm very worried that either this fluid has accumulated very quickly or it is rather large in size. And then the final image is the one at the bottom of the screen. This is a parasternal long axis view. Here the function is normal, the chambers are intact in size, but I can see a small pericardial effusion around the posterior pericardial sac. So moderate pericardial effusion with some RV scalloping there, and then the large one with those angry RV and RA. All right, on to our final set of images. So the one other indication that serves us quite well are patients with right ventricular strain or pulmonary hypertension or RV pressure or volume overload, because there is generally something we can do right away to help alleviate the symptoms in those patients. So the first image that you see here is what's known as the D sign. The D sign is generally seen when the septum is flattened and the left ventricle, instead of looking like that rounded orange that we talked about, now it seems like that a slice has been cut off from the orange and it looks like a D in shape. And the RV may or may not be large in size, depending on whether there was some dilation before the pressure overload. One thing that has to be remembered is that the septum can be made to look falsely flattened if there is a large VSD or a large shunt that can equalize pressures between the right ventricle and the left ventricle. So that's number one. The second thing to remember is that if the parasternal short axis view is obtained in an incorrect axis, then it can also look flattened. How would you know that whether you're in the right axis or not? That's a little bit challenging in the beginning. So what I would recommend to avoid that is to start with a good parasternal long axis view, get all the different structures that we talked about, and then turn your probe 90 degrees clockwise to get the parasternal short axis view. Perfect. So the second clip in the center is that of a parasternal long axis view. And here we can see that the left ventricular cavity is hyperdynamic because the anterior and posterior walls are collapsing on themselves. Earlier in the lecture, we had said that the RV should take no more than the 1/3 of the screen. Here it seems to be violating that rule generally. And then the RV seems to be larger in size compared to your aorta and your left atrium. So one musketeer out of the three musketeers we talked about is larger in size. So this is again concerning for right ventricular strain or pulmonary hypertension. The image to the right top is very similar to the first image. It's an image obtained in the parasternal short axis, and it shows that there is some amount of flattening of the interventricular septum. And finally, you have an apical four-chamber view from the same patient, which shows now that the RV is about the same size as the LV or even a little bit bigger. Remember when we said that RV is generally 2/3 the size of the LV? That rule is violated here. And then if you closely observe the septum, which should always be bowing into the right ventricle because generally that's the low pressure chamber, is now bowing into the left ventricular cavity intermittently. And so that again strongly suggests to me that the pressure on the right side of the ventricles, or excuse me, the right ventricle is elevated. So those are certain things that you can pay close attention to. The last thing that I want to mention is that never use echocardiography alone. It should be used in conjunction with your physical examination, your vital signs, your other pieces of data like labs, your central venous pressure, etc. All of the things together should make sense and form a complete picture. If the echocardiography is saying something different than what the rest of the patient is telling you, then maybe you need to either get more pictures or have somebody else weigh in on those pictures or obtain more comprehensive echocardiography. Whenever in doubt, get a comprehensive echo done by a cardiologist. Um, Always try to practice with a narrow scope and always have a focused question before you even pick up the probe to do an ultrasound exam. And then the last thing is practice, practice, practice. If you guys have any questions, any concerns, feel free to reach out to me and I would love to work with you all. Thank you so much for your time and listening to this presentation.